Ladies and gentlemen, welcome to the August Board of the South Warwickshire NHS Foundation Trust. As you can see, we're still, as a board, meeting digitally, and in the foreseeable future will continue to do so to minimise the risks of COVID-19. We hope anyone watching this, their families and themselves are well in these continually strange times. We have only one apology for absence at the moment from Chris Lewington, who we think will be joining us presently. Any new declarations of interest? Okay, the minutes of the meeting held on the 1st of July. Was everyone happy with the accuracy of those minutes? Please come off mute if you were not. Okay, well, on that basis, I will sign the minutes as a true and accurate record.
Sorry.
Sorry, Rosemary.
Sorry, I didn't get off mute in time. There was one point on page, sorry, I've just lost it now, about the finances on page 6. Second paragraph up from the top, where it states that the Director of Finance highlighted that the Trust had a break-even position of 50 million. And which wasn't quite correct. I talked to Kim, and I think it should have said, highlighted that the Trust had a break-even position, full stop, or break-even position and a cash position of 50 million.
Thank you very much, Rosemary. That's clearly a far more accurate way of describing the situation. Any other amendments to the minutes? Okay, with that one amendment, therefore, I will sign the minutes. We'll therefore go to page 18 of the pack for the matters arising. The first was to get some newly qualified junior doctors. This morning, members of the public, we had a fantastic presentation from a couple of junior doctors, as well as our continuing education team, and I can say, I believe on behalf of the whole board, how immensely proud we were of them and the work that's been done, not just by them, but as the board have received presentations over the last few months, whilst the COVID pandemic has been ongoing. We've seen the enormous efforts made by our frontline teams and the emotional and physical challenges that COVID has had on them and their families. And again, on behalf of the board, I'd just like to thank everyone for the way they not just stood up to the mark, but genuinely were heroes in very challenging situations with a lot of uncertainty, a lot of concerns about their personal safety. And we as a board, and I'm sure on behalf of the whole of the public that we serve, want to again say thank you. So we did that this morning, and then we had the Raising the Group approach to leadership. That was presented on the 20th of July to the Foundation Group subcommittee, and we'll pick up on that later on in the agenda. Sarah would submit an updated register of directors' interest to the next board. That's on the agenda. Helen would bring back a health and safety exceptions report. That's on the agenda. And then Fiona and Helen would integrate their COVID-19 update reports, and we come back to that later, and that's on the agenda. There were Chris and Helen would discuss the role of primary care and the positive actions to be taken so that we don't go backwards from the very real progress we've made over the last 4 months. And I assume, Chris and Helen, that is an ongoing discussion, but it's something we as a board are very well sighted on. And Helen would bring back a regular update to the board workshop on the positive work being undertaken with primary care. This morning, our big session was on cancer performance, so that will come forward in another board discussion. We then had the FTSE Guardian, who is Sue Pike, who does a phenomenal piece of work for us at the Trust, to think about a way of sharing the voice of those members with disabilities, including learning disabilities, And so that's going to come forward on our 2nd of September discussion on the freedom to speak up. And then we had the separate trend data to bring back within the next annual medical revalidation report. And Charles, you'll do that in November. Thank you. Then Anne would present, make a presentation on the work done around recruitment at a future board workshop. That's scheduled for September, as well as including some data within her report about recruitment figures. And we're coming back to that in terms of gender profile, disability profile for next May's board. Then Charles to agree a date for a board workshop on futility. Charles, can you agree a date with Sarah?
Yeah, provisionally it would be November if that can be accommodated then, but I spoke to the team today about that.
Okay, thank you very much, Charles. Then Helen would ensure a presentation on digital innovation come back. That date will be agreed, but we have done some fantastic work on the digital hub over at our Stratford upon Avon site. And maybe Glenn, in your Chief Executive's update, you could just give a flavour of that so members of the public are aware. And then finally, Helen to bring back the winter plan. It feels as though winter never went away given COVID, and that will come back over the next few months. So thank you, Helen, for that. And I note that Chris Lewington has now joined the conversation. Are there any matters arising that I've missed? Okay, so on that basis, colleagues are happy to move forward to the Chief Executive's report. Glenn, over to you.
Thank you, Russell. So firstly, I talk about an independent report produced by Baroness Cumberledge, which, as I say in the report, is hard-hitting. It's on medicines and medical devices safety, and it makes some very serious points, including I refer to an institutional resistance in the NHS to patient safety concerns. Obviously, we don't see this organisation like that, but there are some really important issues that are raised in that report. We are waiting for the government response to that, but no doubt that will result in some policy changes that we'll obviously bring back to the board in due course. Secondly, I report on annual general meetings that have taken place for both George Eliot and Wye Valley over the past month. Wye Valley one included a fantastic video on their response to COVID, and I'd encourage board members to go onto the Wye Valley website and look at that. As a result, I've asked our comms team here to produce a video for our forthcoming annual general meeting, which celebrates the response of staff and looks at just how people have managed through COVID. And obviously, as you said, Russell, we saw a little bit of that this morning in the feedback from some of our medical staff. Then a couple of sections, one on the NHS financial regime. It makes the point within that about in my view, the need to the governance that comes around organisations being much stronger than the governance that currently exists in systems. And so whilst we are very keen to work in systems and need to work in systems, we need to be mindful as an NHS that holding boards to account with the structures that they have around audit committees and clinical governance committees is probably our best hope of keeping momentum and around the NHS, particularly as we go into recovery and from restoration. The NHS performance management regime is referred to, and then in that final paragraph in that section, I refer to the phase 3 letter, which was when I wrote this report was expected to be published. It actually came out on Friday of last week. Talked a little bit about that this morning with non-exec directors. I'll provide a fuller overview of that in next month's report, but it's such an important document. I thought I'd just touch on one or two things that are contained within it, if I may. It is the way that we will manage the NHS and respond to COVID over the remainder of this year, and it links into the 3 billion additional funding that was awarded to the NHS a few weeks ago. So it looks particularly at how we've gone through restoration urgent and emergency services, how we now need to go into recovery of elective services, and we also talked this morning about cancer services and how we get those back on track. There are some important milestones in there. So probably the most significant ones are that during August and then September and then October, we are expected to recover elective activity to the level of 70% for August, 80% for September, and 90% for October, and that's of the previous year's relevant month's figures. So that's quite a big ask of the NHS. Many have said that can't be done. I actually think from a Swift perspective, we're probably in a much stronger position to be able to respond to that than most trusts, but we will need to work that through, and there are similar milestones in there for first outpatient appointments, but it does allow us to use digital solutions to recover those to the 100% level, and also for diagnostics, which is particularly challenging because of the aerosol generating procedures around some things like endoscopy, for example. It then talks about the flu campaign for this winter, which will be a significantly bigger campaign than in previous years, moving from 3 million people being vaccinated to 5.5 million people being vaccinated. And we're preparing, hopefully, for a COVID vaccine during this winter also. The day prior to that coming out, the People Plan was also published, and this document we've been waiting for since last autumn and has been delayed for a number of reasons. The People Plan contains much of the emphasis that I think I previously trailed at board, but the context is now different. The context of having gone through COVID, it particularly emphasises the need to maintain some of the support for staff, the focus on staff wellbeing, which obviously we've been doing, looks particularly more so than it would have done at flexible working, but also the recruitment needs of the NHS, which I think post-COVID we're probably in a stronger position to recruit staff to the NHS because it's a great place to be and a lot of people are showing an interest, but also it's more complicated in terms of international nurse recruitment, for example, and international travel. So I'll bring that back in more detail next month. The final section on the report talks about lessons learned virtual board, which has been really powerful way of capturing the things that have been going on through COVID, and we're doing this in all 3 trusts in the group and sharing across the group those learnings. A lot of it is the rapid introduction of things that we were hoping to do and we thought would take longer, and we've been able to accelerate those during COVID, which has been positive. And then finally, Russell, you asked me to add, and I'll add this in words next month, the digital hub. We'll be doing a formal launch of this, probably a digital launch because it's digital, but also because of the COVID situation. But over in our Stratford site, we provided space and did some buildings work for a room, which was then kitted out by Specialist Computer Centres, which is part of the Rigby Group, and we're collaborating with them to bring clinicians into this space to work with industry to innovate digital solutions. We've already got some live projects in the trust, which we'll be evaluating in there, but it's absolutely fantastic, and it creates a very different atmosphere, which will hopefully allow us to think outside the box and come up with different solutions. So I'll bring a bit more on that to you next month. Happy to
Thank you very much. Thank you, Glenn. Questions and perspectives to Glenn. Anne.
Hi, thank you, Russell. I just wanted to say that, given that the People Plan has already landed and we won't talk about it for another month, just to give assurance that it does align very well, or our current workforce plans do align very well to it, particularly the leadership work that Dan's prepared for the report this afternoon.
Thank you, Anne. And any other questions or perspectives to Glenn? Okay, Anne, if I could ask you to take your raised hand down, that'd be great. The only thing I'd reinforce was the point Glenn made about how challenging for the NHS the 70, 80, 90% recovery profile is. In the COVID situation of having new protocols for PPE, social distancing, the 2-metre rules, frankly, the staff being tired emotionally and physically and needing holidays after the COVID intensity that they have lived through. Members of the public should be aware it's a big ask to get back to 90% by October, but you can be assured that this board will do everything it can to achieve those numbers. So we'll move on then to the Integrated Performance Dashboard. And Anne Cole, do you want to introduce it for us, please?
Yes, thank you. Thank you very much, Russell. So the Trust Performance Integrated Performance Dashboard was drafted, obviously, before we had clarity from the recently reviewed Phase 3 letter that Glenn has referenced. And in future, this report will include updates to the board on our progress against those milestones. Lead directors will go through their sections in detail, but as I was reading through them and drafting this report, what caught my attention was really the work that's underway to keep patients and staff safe. Patients safe through the continued introduction of the blue, yellow and green areas, and also how we're working as outlined in the Director of Nursing report, to keep those patient ward moves as we have the reduction in the number of COVID-19 patients. Also linked to that is the work underway around supporting and recognising the caution some of our patients experience who are required to attend hospital, and the work that's underway, particularly with our primary care colleagues, so that people understand the risks of not having their systems investigated versus the possibility of contracting COVID-19. So an important point in terms of our organisation and trust safety. And keeping staff safe, particularly the risk assessments that's been detailed in the Director of Human Resources reports in terms of the percentage of the COVID-19 risk assessments completed. We've seen improvements in falls, and it's pleasing to see that. And also at this time, although performance is not where we want to be, and the Director of Operations report sets out the challenges there in terms of the delivery of those regulatory performance targets, it is pleasing to see and acknowledge the opportunities that we've got in terms of preparing for go live for the national NHS 111 first, the work that's underway around the system points prevalence study to capture our innovations, and you will really understand what we have achieved through the implementation of the discharge planning guidance. And those were the points that I wanted to pick up.
Thank you very much, Anne. Questions or perspectives to Anne, or are colleagues happy to move on to the detail? Okay, Anne, thank you very much. We'll move on then to Fiona. Fiona, over to you.
Yeah, thank you, Chair. So generally for the quality and safety outcomes, performance remains stable and particularly good in some sections, namely the falls and the medication incidents that remain low. The work that we've been doing this month on those pathways, as Anne alluded to, has reduced the number of bed moves, which is good from a patient experience and a safety point of view. As you see from the dashboard, there has been a pause nationally as well as locally on a number of indicators, but we are expecting that requirement to change and for us to switch back on FFT, dementia screening and the catering surveys in the next month or so. So you'll see figures against those shortly. And I suppose the focus for this month and ongoing will be to recover the patient care indicators, because that is lower than what I would expect it to be. So we're doing some detailed work on that. That's all from me. Thank you.
Thank you, Fiona. Any questions or perspectives to Fiona? What's worrying you most, Fiona?
What's worrying me? A combination of a difficult winter and a COVID peak. Saying that, we're in a better position, and my staffing paper, and I'm sure Anne Pope will allude to, our staffing position is better than it's ever been going into winter, so that will give us more resilience. The requirement to social distance and PPE, hopefully, if I'm feeling optimistic, will give us less pressure in terms of flu and norovirus, hopefully. So there is a bit of pit of my stomach gnawing, just in terms of that. As a medical student said this morning, that sense of doom coming for winter. But I think we've got a strong plan, which I think Helen will be presenting next month.
Super. Thank you very much, Fiona. Okay, colleagues, happy to move on to Helen's report. So Helen, the Director of Operations report, please.
Okay, thank you very much, Russell. I think I've said for the last few months in relation to the Director of Ops report that this does reflect the impact, and it is, if you look through the SPC charts, you can see very clearly where COVID has impacted us. But what I would like to provide some assurance to the board is that we are steadily recovering the positions. ED, the A&E target is a little bit fragile at the minute, but what we have seen is a significant return in ambulance arrivals, and we're starting to see, particularly through July, although it's not reflected in June, almost pre-COVID activity within the A&E departments. I think there's some really great work that we are working on in a sort of a pilot scheme around NHS 111 and our new model around same-day emergency care. And we're getting some support from the national team, as they're really interested in the work that we're doing around that, and making sure that we've got all of those pathways in place to prevent patients unnecessarily attending ED and different pathways on that. So I will update the board on that next month, because the go live date for our slot across the STP is the 28th of August. So lots of work to be done in the interim on that. I think if we start to look through the report, a couple of things that I wanted to pick out: that we are starting to see the return of our inpatient elective activity, and so our elective spells are starting to rise, which is a good thing. And we will start to see that improve further through July and August. And obviously, relating to the stage 3 letter that Glenn has already mentioned in his update, we need to be putting plans in place now to restore our activity to a minimum of 90% of pre-COVID activity. We're doing some. We're managing our stranded patient numbers, although there is a slight increase in the numbers there, but all patients are being monitored on a day-to-day basis so that we can unblock any delays. I know that the stage 3 letter doesn't talk about particularly around the RTT 18-week performance, but I think it is worth highlighting to the board that, and as I've said before, this one breaks my heart, that the position that we are in with our 18-week performance, and the paper really sets out how that has started to decline over the COVID period, and how then we are, as part of the letter, to be able to start to look at the long waiters and looking at the size of the waiting list. But our position will deteriorate further in July, and further on in the second chart, when it talks about the profile of the waiting list, that's that big peak that you can see is about to tip over into 18 weeks. So that will further reduce our RTT position. We should start to recover very slowly on its own after that, because you'll see that there is a real dip in those, but it doesn't mean to say that we can rest on our laurels, because what we then have is a long waiting list with patients that are over 18 weeks waiting, and we will need to be able to deal with that that large number of patients on the waiting list. From a diagnostics point of view, that is beginning to improve significantly, so I'm really pleased in the turnaround of that, and you'll see further improvements on that as we go through July and August. And I'm sorry, in the report there's a couple of, I don't know how that's happened, and there's a couple of charts missing. So we talked about cancer this morning. What you have in front of you within the report is the 2-week wait performance. Again, that is starting to look better than the last 3 or 4 months. Our 62-week position has been poor, as we've discussed a number of times here, but we are starting to see improvement of that position. We also have started to see reductions in the number of patients that are the long waiters within cancer, particularly those patients that are waiting over 62 days and 104 days. And they have, actually as of today, they are down to the pre-COVID numbers that we have. We've still got work to do on that, but the team have done significant work in making some real inroads into that. I'll pause there before I go on to the out of hospital bit, Russell, in case there's any questions on the performance.
Thank you very much, Helen. Glenn, I think you had your hand raised first.
Yeah, it's just to pick up Helen's point. In the phase 3 letter, there isn't a specific mention of the RTT standard, but what it refers to is the 52-week wait position and an expectation that we eradicate any 52-week waits across the NHS by the end of this financial year. And obviously we'll be watching this one. There's no reference to the overall percentages, as Helen says. I think one of the things we need to keep an eye on, though, is some of the data that Helen's been sharing with us shows an increasing. So whilst A&E attendances are below pre-COVID levels, overall emergency admissions are pretty high and pretty close to previous levels, and we have been seeing some more activity from the Solihull area. Board members may recall that a few years ago they stopped an immediate walk-in A&E, but during this COVID period they've also stopped taking urgent care into that site. It's now an elective site only. So we expect that to result in a regular shift in activity to us, and that's something we're keeping a close eye on.
Thank you, Glenn. And Jeff.
Yeah, thanks, Russell. I think Glenn's just almost answered my question, which to Helen was, whilst the activity in ED is moving up, is the mix changing or returning back to pre-COVID levels? I was particularly interested around cardiac services, given I think it was a Leeds report that something like 40% of heart attacks have been missed over the past 4 months because of COVID and people's resistance to going to A&E, and whether we were starting to see any indications of recovery in that area in particular.
Okay, thank you, Jeff. When we looked back and looked at the types of attendances that we have been seeing, and we can look at that on a month-on-month basis, we haven't seen a fall off in terms of cardiac arrests and heart attacks and strokes. So during the COVID period, we have continued to see reasonable numbers of those. So it doesn't look like we have missed those. What we had seen a reduction of during the pandemic was people turning up with many of the minor injuries and things that could have been treated elsewhere or have got better on their own. And we are starting to see a return of that. Ambulance conveyances are almost at that pre-COVID level, and what we are seeing, which is putting pressure into our A&E system, is that they're coming in batches again. So the other day we had 11 ambulances queuing outside, and because of the zero tolerance around corridor waiting, it means that we're caught between the devil and the deep blue sea. We can't put them in the corridors to wait, but we're not allowed, but we have to offload within an hour, and so we are having to redesign ED so that we can allow offloading, but it isn't in corridors, so that we're trying to find additional space within ED so that we can make sure that patients are offloaded and the ambulances are released. I think from a Solihull point of view, we are seeing an increase in that activity. We are starting to see that already, and my intention is to detail that more in next month's report, which will give us a greater flavour as what we're starting to see coming back from it from a July point of view. It is causing some concerns within the teams, while most of that appears to be patients that are attending and then can be discharged. One of our big worries for winter, and we've talked about this a number of times before, is that if that becomes more of an ambulance attendance and patients then need an inpatient stay, we then potentially can end up, if we don't get our pathways right from a discharge point of view, is increased numbers of stranded patients for out of hours. So the team are all over it, and I think that the one thing that I didn't mention was the point prevalence survey. So if you cast your minds back a few years, we started with a point prevalence survey that talked about if all the patients were in the right place for the system, how much money would that save the system? And we've done that a number of times over the years, and often once or twice a year. But what I have asked what we have asked the system to do is do it again, and do it now before we resort back to any of our pre-COVID ways, to see whether all the things that we have learned through COVID have benefited us in terms of the patients being in the right place. And I think the work that we have done around discharges and patients being at home rather than being in a care home, because many patients' families have responded very well as wanting patients to be at home and to be cared for, then I think it will be really interesting to see and if there are any differences or any improvements that we've seen about patients being in the right care. So that's going to take us a while to get through. It's been a big ask for the system, but everybody's responded really well, so we just need to input the data. But I'll be quite excited to see that come back, to see whether COVID has had some impact on making sure that we get patients to the right place.
Thank you, Helen. Thank you, Jeff. And keeping the pace going, Cyril and Tracy.
Yeah, Helen, you've spoken about stroke volumes not falling off across COVID. What we've got in the report is quite blunt in terms of measurements. Obviously, some of the plans for other measures haven't as yet materialised. I just wondered if you could give us a flavour of how those key areas of access to specialists, timely access to specialists, how that's been going across COVID.
Thank you. So we've still got work in progress, unfortunately, on the dashboard, so I apologise for that. During the COVID time, what we did introduce was a green and red pathway for stroke patients. And for those patients that came in clearly that were requiring acute care, obviously we needed to manage those patients in an area where if they were tested positive as COVID or we were waiting for their result, then they were in a side room, which often meant that those patients were sat in our acute medical unit for at least 24 to 48 hours whilst we were waiting the swab results. What that did mean is that the team were then going to the patients rather than us being able to place the patient in Victoria Ward, for example. So the pathway had slightly changed during that, but access to CT and all of the support teams was all available there in terms of how the teams were working and making sure they had appropriate PPE. As soon as the patients were able to be stepped down from acute care into subacute care, we put some additional resource out into Felden Ward, medical resource, so that we could step patients away really quickly into a green area once they were if we established they were COVID free, because actually these patients were very vulnerable. And so that was on Felden Ward on the Leamington site, which was classed as a green site, to making sure that we're keeping patients safe and keeping that flow through. The stroke pathway work, particularly around the reconfiguration across Coventry and Warwickshire, has been reignited, and we are working through all of those processes now. And the first part of that is the early supported discharge team and the recruitment to that service, so that then all acute strokes will be directed to UHCW as their first port of call, and then obviously we would then receive patients who actually weren't then a stroke or for rehabilitation. So there's work ongoing on that one.
Thank you, Helen. Again, very comprehensive answer. And final question from Bruce, please.
Thank you, Chair. Helen, or maybe Glenn as well, there's been some recent press about new tests available with quicker results. And I wondered if you could comment on whether that was coming our way and how helpful that might be. And the other question related is any recent changes in infection control standards to which we would now subscribe and follow, which would be helpful in getting throughput better in the trust.
Okay. Glenn?
Yeah, so in fact, I'll have to leave this call a little bit later to join the national call talking about those rapid tests. So rapid turnaround tests, which give you a result within around 90 minutes, is what you probably heard in that press release, Bruce. There is a supply issue at the moment. So the intention for the NHS is to get to a position where we have enough of that testing capability to test all urgent admissions to hospital. At the moment, we fall quite significantly short of that, and the one supplier that we have, which is from the States, has been restricting supply to the UK. So we're just about to go into a process of getting 2 new products that are UK manufactured that will be available over the next 2 months. So by the time we get to November, we'll have sufficient supply to be able to meet all emergency admissions. But between now and then, we certainly as a region, we don't have the same access as other regions. So we're making an argument to try and get more access. But it's really important, therefore, that those tests are used for the right use case. And so real emphasis on using it so we can manage those front door admissions and get the bed usage right, rather than any other usage like football players, etc., that don't need rapid testing. So there's those discussions going on at the moment. And your second question, was that more for Helen? So what was the second question? Sorry, Bruce. You're muted.
You're muted, Bruce.
It's about our infection control method. Procedures have been very effective. What's new? What's about to happen? And how's that helpful?
Yeah. Okay, so there was new NICE guidance a couple of weeks ago that helpfully introduced a degree of pragmatism to the testing of elective admissions to hospital. Prior to that guidance being issued, we were required to advise the individuals to isolate for 14 days, potentially the whole household if you read the guidance. But the new guidance is more flexible. It allows particularly patients coming in for non-invasive, less invasive procedures, so general anaesthetic, for example, to have a shorter period of isolation. And therefore that will help, because there are a number of patients that were just simply being asked to be removed from the waiting list as a result of being presented with that kind of big isolation issue. So there's more pragmatism and local flexibility associated with it. We're also hoping to get ourselves as an early pilot of some new home testing capability. So at the moment, our elective admissions need to be swabbed on a hospital site prior to admission. The new testing kit should allow the individual to do that and mail those results in, so they don't have to visit the hospital prior to it. Other than that, the main kind of urgent care infection prevention arrangements continue as per the guidance that I think you reviewed at Quality Committee.
Okay, guys, we really do need to pick up the pace a bit now. So, Jeff, your hand is up. Is that a legacy hand, or do you want to quickly ask something? Thank you. So, Helen, just quickly on out of hospital, please.
Yes, thank you. I just wanted to highlight really the continued good work within out of hospital services, and there's just a few key items that we've reported here. So really good performance across each one of those, and it's really highlighting the continued work and the huge amount of work that the out of hospital team have continued to do to make sure that all patients within out of hospital settings are kept safe. The only thing I really want to take, because I think the report is very self-explanatory, is that Tracy and I are working through a different type of report on out of hospital, because I don't think this report in its current format really sets out some of the performance things that we would want to talk about at board and give board a highlight on, and these are just sort of the kind of KPIs really, and I think that we could be a bit more narrative in that in relation to that. So you will see the out of hospital bit change as we move forward and Tracy gets more settled into her new role.
Thank you, Helen. Any questions to Helen on out of hospitals? Just on a really practical, and you may not know the answer to this, have we re-established podiatry services out of hospital? Because I know for a lot of patients it's a very intimate but very needed service. Do you know if we've got all of our podiatry services back up and running?
So I actually can't answer that, but we are working through the re-establishment of everything back in a safe way. I don't know whether Anne knows or Fiona's got a handle, but I know we are working through re-establishment.
Fiona, by chance, do you know?
Yeah, I believe we have, only because we've looked at the ventilation in some of the community clinics recently with that in mind. So I believe Belinda has restarted all of hers. She will continue to do some of the remote consultations that started through the COVID pandemic, and because they were working well, but the face-to-face have also started.
Okay, great, super, thank you very much. Moving on then to Anne Pope's report, and if I can ask executive colleagues, we are running a bit late now, just to be even more succinct than they would normally be. Anne.
Thank you, Russell. I can help with that. So I think I've set out in the report considerable detail in relation to where we are with recruitment, and you'll see that it is a positive position. At September workshop, Matt Clarson, who leads this piece of work, is going to come along and talk to the board about some of the innovative ways that we're looking at in terms of recruitment, and also about how we're making sure that we engage effectively with new recruits as they go through that pathway in the different world we find ourselves. I've set out again a lot of detail in relation to sickness. What I would say, and I think I said last month, is that this is something that we need to look at from a trend perspective, but in a sort of start again, really, because we are in a different place. You'll see that sickness has reduced significantly. We're hoping that that's because what we're hearing from staff is that there is an increased sense of well-being from some staff who are being able to work more flexibly and in an agile way that they haven't previously been able to. But as we move forward, we'll see the people who've been shielding come back into the workplace, and that may also impact on the sickness figures. We don't know that yet. So I wasn't going to talk about that any further. Anne mentioned at the beginning the risk assessments that our managers have been undertaking, and I'm pleased to report that since this report was drafted, we were able to complete an external return on the 31st of July that indicated that all of our staff who were available had had a risk assessment, which we were really, really pleased with. And it's a huge thank you to managers, because that's a significant task. What we need to focus on now is making sure those risk assessments should be dynamic. So making sure that they're reviewed as someone returns from maternity leave, from sick leave, or something changes in relation to their role. And then Dan has set out for me a summary of and a leadership update. And I wasn't going to go through that. I think there's quite a bit of detail here. What I would say is probably the biggest risk around this piece of work is Dan realising his own ambition and me helping him manage that, because he has had, he's lost two key members of the team between Swift and George Eliot. And while he's in a good place, he's recruited a really good individual, there will be an induction period. So I'm working with Dan to manage his own expectation around that. And
Super,
that's all I have to say, but very happy to take any questions.
Thank you, Anne. Any questions or perspectives to Anne? Jeff.
Yeah, just very briefly, Anne, with the excellent sickness numbers starting to come through, and if there is such a thing as an excellent sickness number, is this being balanced against people being able to get away on holiday and taking their annual leave, rather than that stacking up as a result of sort of end and winter coming at the other end? Has that been able to assist that balance?
Absolutely, Jeff. We have talked to managers right from the outset. That I've done that along with Helen and other senior managers, to encourage staff to take their leave regularly, because we were very conscious, even while we were going through a difficult period, that we needed people to rest and recover. So we monitor that on a quarterly basis. My team do that, and we talk to any managers where it looks as though there are areas where annual leave's not being taken.
Thank you, Anne. And therefore, moving on to Kim's report, the finance report. Kim, how are you feeling about the money?
Thank you. I'll keep it relatively short. So, as you'll be aware, we're currently in this block arrangement and we're still required to deliver a break-even position with some block allocations, and we're allowed to claim a top-up element. For the period reported, we claimed 656,000. Sorry for this, the report was incorrect, but it's actually £656,000 over and above the allocation that we claimed as an additional top-up to break even. Our cash position remains strong at £50 million, but that's reflective of the fact that we receive a month's worth of allocation in advance of the current period. And also it reflects the cash balances that we're holding back to in reflection of our capital programme, which we've yet to spend. Although we've got commitments and plans to do so. The other bit I think to note is probably around the work linked to the phase 3 letter that's just been issued, where it's been confirmed that the current block arrangements are going to continue for a further 2 months, so taking it to the end of September, and there'll be a new finance regime for the second half of the year, although that's still being worked through, but we expect that to be some sort of block arrangement as well, albeit some elements that are going to be linked into system partnership and the restoration of our elective services. So we'll get more detail when we get more detail, but that's all I've got to say at the moment.
Thank you very much, Kim. Questions and perspectives to Kim, but keeping the pace going. Glenn?
I think it was Jeff first, Russell.
No, I think Jeff had his hand.
Oh, was it legacy hand?
Sorry, I'm waving my hands around all over the shop. I've gone.
Apologies. Okay. So, Kim, it's probably a question that I'll keep asking you each month for the rest of the year now, which is within that cash flow position, could you let us know how much South Warwickshire CCG owe us, please?
Okay. Well, there's a difference between the two organisations of about £11 million. We've been in active conversations with the CCG actually every 2 days. Actually, I've got another one tomorrow to close the gap. I think, given the conversation just yesterday, I think we're heading in the right direction. So so that's where we are. So we've got another meeting tomorrow, but we seem to be heading in the right direction. So
just for clarity, Kim, just so everyone understands. So based on the work we've done, and where we can, based on the work we have historically done, and our ability to evidence the fact that we've done that work, the CCG owe us £11 million.
It's not quite as simple as that, but yeah, there's a difference between what we think they owe us and what they think.
No, but based on our evidence, yeah, based on the work we've done and the evidence we have, we believe they owe us £11 million.
Yes, and we're working with them to.
I understand that.
Okay.
Yeah, I understand the next bit, but that's what our records show. That's great. Thank you. Any other questions to Kim? Okie dokie. So fingers crossed on that negotiation, Kim. Never easy negotiating with colleagues, which we're aware of. So moving on then to the mortality report. Charles, is there anything you particularly like to pull out of this?
No, just really to say that mortality remains very stable within control limits, and to just point out again that because there's no risk adjustment for COVID yet, you will see that although the shimmy is remaining stable, that there is an apparent spike in the indicators for April, but there's no control yet. We've fully recruited to our medical examiners post now. We're soon hopefully get the IT system, and we also will be recruiting a medical examiner's officer to help support them.
Super. Thank you very much, Charles. Any questions on mortality from colleagues? Rosemary.
Charles, just a question on clarification. The shimmy analysis that's in the report, I actually can't read what it says. So I just wondered whether you could just explain to us what the pink bar, which for April, which is high, what that is, and what the green line is, just so that we understand.
Okay. The green line is the nationally validated figure that we have. Mm-hmm. And actually we have a slightly more updated point where it's dropped to 0.97. The bar that's gone up is our CHKS, which is a benchmarking company that tries to calculate it for us. But that is, they have no risk control for COVID, because nobody knows what the mortality of COVID ought to be. So shimmy is not counting COVID deaths, and that's them putting it through their model. So COVID deaths in the, without COVID risk adjustment will be for pneumonia, but the mortality for ordinary pneumonia is actually much lower than for COVID pneumonia. Hence, the apparent risk-adjusted mortality without the appropriate risk adjustment looks high.
Right.
I hope
Thank you,
that's
Charles.
clear enough.
Yeah, no, very helpful. It's always a challenge understanding what's happening with the denominators and numerators and definitions. Colleagues, happy to move on? If I can ask us all to keep the pace going, that would be helpful. Thank you. So we're on to the nurse staffing report. Fiona.
Yeah, I'll keep this brief, Chair, thank you. Just 3 points really. One, to say very similar to what Anne Pope said earlier in terms of our nurse staffing. Vacancy position has continued to improve since September really, and is looking very healthy at the moment. You remember that there was a worry at board in terms of particularly the acute staffing position, which was in September at 22% vacancy, and it's most recently reported at 14%, so that is a significant reduction. Equally, I haven't given you the figures here, but we had workforce strategy meeting this week, and the retention figures, the turnover, voluntary turnover of staff, have also had that dramatic reduction. So both of those are really helping in terms of that staffing position. And just to give the board assurance that we are starting to recruit and plan for a staffing base in terms of additional staffing for managing winter capacity. That was all.
Thank you, Fiona. Fairly much more assuring. Questions and perspectives to Fiona? Okay, thank you very much. I think in these uncertain times, I could not encourage young people thinking of going to university to think about a career in medicine and nursing. It's a great time to join the NHS, and we would love to have you on board and be one of the heroes that has worked in this trust and around the NHS. So please come and join us. Moving on then to the Clinical Governance Committee report for the 8th of July. Bruce, any particular points you want to pull out?
I'd just like to verbally emphasise that item 4, I was particularly pleased to see the empathy and compassion throughout the report that I have noted. Otherwise, questions, please.
Thank you very much, Bruce. Any questions to Bruce on the report of the 8th of July meeting? Okay, thank you very much, Bruce, and everyone involved in the Clinical Governance Committee. Then we're on to F&P, the verbal report for the 30th of July. Simon.
Okay, thank you, Chair. So a couple of things to report, really. We had a discussion at the meeting about how we might refresh F&P and to keep it relevant and adding value. And as a consequence, we have decided to continue to focus on the numbers, of course, and performance and key performance concerns, but to focus much more on deep dives on key issues that we have. So, for example, at the last meeting, we did a deep dive on cancer, and I think that went particularly well. And be interesting to see whether that turns out to be the right format going forward for some time for F&P. The things to highlight, we've spoken about cancer a lot today, so I don't intend to say too much about it, other than to say we were very assured that the actions in the immediate outlook to bring cancer around were well founded and well thought out. But there's still some need for greater assurance around the long-term embedding of those actions to make sure cancer continues, once it's fixed, at an acceptable level for an outstanding trust. We also had a debate in the performance dashboard, and I think there's some the A&E needs to be under the microscope, and is, and we need to watch that carefully. But financially, I think we're in sound condition, managed well as usual, as indeed is the trust at large. And I think the significant thing that stood out as a very positive thing was the good work that's been done on stranded patients. So overall, I think the level of assurance is very significant. And the things that we just need to keep an eye on are long-term trends in cancer and A&E and RTT, all of which Helen is on board with and mentioned in her report. Anyway.
Thank you very much, Simon. Questions, perspectives, Glenn, before you disappear for your call.
Yeah, thank you, Russell. So following the workshop discussion this morning, we had a catch up with execs at lunchtime. We've agreed a process where we'll evaluate the need for investment in some of those cancer areas, and that will come back as a business case to board next month. We'll also be looking at the winter, at a rough situation in terms of what we need to invest in for winter, so that we can ensure that we meet the restoration and recovery milestones. So that will come back to you soon.
Thank you very much, Glenn. And Rosemary, you have your hand up. Okay, I assume it's been taken down. Thank you. Okay, so colleagues, happy to move on, but thank you, Simon, for your leadership of F&P. We've then got the Foundation Group Subcommittee report for the 20th of July and annual report. Chris, anything you want to add to this?
Not particularly, just to say it was really good to see the traction that we have on the IT strategy, and the presentation from Andy was really good. And just a plea to keep an eye on social care over the coming months, given the financial crisis that they are in at the moment. They will have to start planning for 21-22 now, and so I perceive there to be some major challenges going forward if their financial situation isn't resolved very soon.
No, absolutely. There was a very interesting report undertaken by the Department of Health and Social Care on the economic vulnerability of the care sector.
Yeah.
Basically saying that both for care homes in this particular case, relying on local authority funded sources, they are extremely vulnerable, literally only 1 or 2 months away from going bankrupt. So addressing the challenges in social care is going to be key if we're going to be able to look after our population in a way that doesn't create problems within the NHS.
And
Point well made.
Yeah, and the challenge is that they have to, every local authority has to balance their books. So
absolutely.
Unless there's a resolution very soon, it will have an impact on us.
No, absolutely. Thank you, Chris. And questions and perspectives. Sue, you wanted to make an observation?
Yes, just to say thank you to the committee for taking forward monthly updates on digital and IT for the group, because I think that's so key this year. So we've got something on the agenda here proposing quarterly, and I think those two things together will be really helpful. So thank you.
Great, thank you. Someone's got a dog barking in the background. Any other questions? Otherwise, we'll move on to the patient experience quarterly report. Okay, so Fiona, back with you.
Yes, the only thing, thank you, Chair, the only thing I wanted to pull out from here, because it is a standard report that you see every quarter, and performance continues to be good. The only thing I wanted the board to recognise is the impact on COVID to the bereavement team and how they have really changed the service, have been innovative and supportive to families, to patients, to staff through this time. As you saw on Charles's report, the huge spike in the number of deaths in April, predominantly due to COVID, and that did put a strain onto that service, but they really stepped up and facilitated where possible that those bereaved families and patients were supported, and I wanted to publicly thank them for that.
Thank you, Fiona, and if you can give the thanks of the board to that team, and I'm also conscious of the enormous work that goes on in the chaplaincy service in that regard as well. Any questions to Fiona on the patient experience quarterly report? Okie dokie. So we stay with you, Fiona, for the CQC quarterly update, including insights report.
So this is a fairly stable report, really. We have an insights report that is published every month, and it's a slightly improved position from the previous month. The report generally gives, I hope, board assurance that we are still tracking the actions from the CQC report from September, and closed the majority of them. There are a couple that have caused some difficulty where some of the action is not completely in our control, but we are still working on those.
Thank you, Fiona. Any questions or perspectives, Rosemary?
Yes, Fiona, just wanted to come in on the Sensign. I think a few months ago I asked the question, were we concerned about Sensign in terms of holding, not getting the new changes in, and I understood at the time that most of the issues then were with us, but from your report it looks like we're waiting on Sensign again to deliver the News 2 implementation, and I'm just, it's been a long time coming now, and I'm just flagging concern.
I wonder if I could ask Helen to come in here, because due to
That's fine. So Helen.
Yeah, it is sat with us, Rosemary, and we stopped it during the COVID pandemic because we couldn't allow people to come in and train staff on the wards, and we needed a significant downtime, and I was uncomfortable having a downtime where we didn't know what the pandemic would give us. So now we're in a better position. We are working through that, and we're just trying to find, because everything has slipped, so within our digital programme now we're just trying to find the time for the go live for that to happen. So it is in hand, we're on it. It just, at the time, because we believe that we are still a safe organisation without doing News 2, that it was not a priority.
Okay, so perhaps the word slightly, it's in our hands.
It is. It's completely in our hands now to make this happen.
Right.
Thank you, Helen. Thank you, Fiona. And any other questions to Fiona? Okay, thank you. So we then move on to the Digital Health Board quarterly report, which we referred to earlier. Helen, anything you'd particularly like to emphasise?
Thank you, Russell. No, I think the report is very self-explanatory, and it's very well set out. I think it's just pleasing to note the significant amount of work that we have carried on doing during COVID, and what a difference using technology has made to how we deliver care during this period of time. And my plea to the team, and they are massively stepping up to this, is that we continue this pace and continue with the innovation and the new ways of working that we have established during this period of time. The only thing I did probably want to pull out is that Adam, who has actually been leading on the development of the digital hub, and he's been the management lead for that, has done an amazing job in getting that up and running, and he has mentioned a little bit of that in his report. But I'm sure once it is all up and running, he'll want to probably come and talk to you about it, because Adam has been instrumental in getting this off the ground.
No, great. And on behalf of the board, I think we'd all like to thank Adam, and equally Ben on the clinical side, for the work they're doing under your direction. Any questions or perspectives to Helen? Rosemary, your hand's up. I'm not sure whether it needs to be. Okay. Colleagues, happy to move on. So thank you for that, Helen. But we're with you again for the health and safety exception report.
I know. I promise there won't be so many papers from me in a next board meeting. It's been a trial putting them all together, I can tell you. But this was an assurance piece, really. It has been through Health and Safety Committee, and this is just setting out what we have been doing around social distancing, both in the inpatient areas and in the non-clinical areas. And through our receptions and other areas that we have been dealing with. I mean, from what we discussed at Health and Safety Committee yesterday, there is a lead time for some of this, particularly the screens. And screens aren't always the answer, because we know that if you put a lot of screens up in an area, it stops the airflow. And so it's the ventilation piece of work that we are working through, and really trying to understand that before we go ahead and put lots of screens in, because that could potentially make the situation worse. So I think it's an assuring report that we are on it, and we are doing all of the reviews that are in there, and some of the delays are just around because everybody's doing it. It's about the delivery of the products.
Thank you, Helen. Questions and perspectives. Bruce, please.
Thank you, Helen. All looks very good. I'm pleased to see it's through Health and Safety Committee. Could you just confirm that as we refer back to the conversation that triggered the request for this, that staff areas such as changing rooms and coffee break rooms are included under 3.2, I presume?
Yes, they are. So they're in all of those areas, as we have had to have done on this corridor. We're supposed to assess those areas and make sure that they are either COVID free or they have the right amount of people that are allowed in there. Obviously, we will have done that background piece of work. We need to now be doing the checking piece of work that actually people are adhering to that guidance.
So thank you, Helen.
Thank you.
Yeah.
And I think Sue William-Tracy had an observation.
Yeah, I just wanted to share, Helen, it's really good to note the dynamic nature of what's written in the report and what you just added to it, and the continuous improvement aspects as we learn and more about this pandemic. So thank you very much for bringing that to life.
Thank you, Sue. Colleagues, happy to move on. And then finally, I think this is your last report today, Helen, the COVID-19 briefing update. Obviously, we've been briefed as a board substantial on that throughout the day.
Yeah. I don't think there's anything particular I want to pull out, Russell. The organisation currently is in a very stable position. We have, and I almost don't say this because normally when Glenn does it, it causes a problem, but we only have one clinically positive patient in the organisation, and we have had no swab positive patients in the organisation for some time now. So what we are doing now is working towards putting some normality back into the organisation, so that people, if ever possible, our really hard-working staff can get a little bit of a downtime before we do move into winter. So Fiona and I have actually pulled this together in terms of the numbers and the activity, so we'll just take any questions.
Thank you. Any questions or perspectives from colleagues? I would just make the general point to members of the public that until you have been vaccinated, until a vaccine is available, the best way you can help society, loved ones, yourself, is to wash your hands thoroughly, wear a mask, socially distance, and if possible, self-isolate as much as possible. This is a disease that spreads through social interactions, and we're seeing that around the world. So we each individually have a part to play to prevent the coming back of another COVID-19 outbreak. Thank you, Helen. Colleagues, happy to move on to items for noting and information. The first of which is the highlight of many of our board meetings, the summary of ratified policies. Anne Coyle.
Thank you, Chair. Yes, so just on the executive opinion, just in the last sentence in that first paragraph, it describes that the clinical commissioning group has not supplied clear performance requirements for the trust, and therefore at the end of Q1 the contractual plan remains unclear. It's just to assure the board that there is work underway to agree that activity plan for 2021. The phase 3 letter has been referenced a number of times, will be taken into account, and that action should be completed at the end of August. The papers here really to agree the end of year board assurance framework for 1920, to approve the board assurance framework for 2021, and to make the board aware of the red risks that are on the organisational risk register. Happy to take any questions.
Thank you, Anne. Any questions or perspectives from colleagues? Colleagues happy therefore to note and accept the recommendations that Anne made. Okay, thank you very much, Anne. We'll move on then to the appointment of consultants. And anything you want to add to this, or should we just take it as read?
Happy for you to take it as read, Russell. Thank you.
Any questions or perspectives from colleagues? Okay, thank you very much, Anne. Then we've got the updated register of directors' interest. Anything you wanted to add to this, Sarah?
No, happy to take as read, Russell. Thank you.
Thank you. And just to confirm, that is still accurate. Colleagues, please come off mute if it's not accurate. Okay, and then we've got the open meeting minutes from the Clinical Governance Committee on the 10th of June. Anything you wanted to add, Bruce?
No, nothing to add.
Any questions from colleagues? Thank you to everyone involved in that committee. And then we've got the F&P of the 25th of June. Simon, anything you wanted to add?
No, nothing to add, Russell.
Any questions from colleagues? I'd just like to add thank you to everyone involved in F&P and also the way F&P is evolving to help be fit for purpose going forward. Any other business? Please come off mute if you've got any other business. Okay, and then thank you. So, Sarah, do we have any questions from governors or members of the public?
No, we haven't got any, Russell.
Okay, thank you, Sarah. Therefore, I look forward to meeting you all again digitally at the next meeting, which is on the 2nd of September at 2 p.m. Zoe, could you please turn off the recording?